Hello and welcome to this edition of InnerView. I'm Amanda Chudnicki, and today we're in Ann Arbor at the University of Michigan Hospital. We're going to be discussing the dangers of H1N1. Joining me today is Dr. Lena Napolitano, Director of the Surgical ICU at the University of Michigan Hospital, Morgan Chozik, daughter of a current H1N1 patient, Tina Chozik, the wife of that same H1N1 patient, and Rob Wanacott, staff nurse in the SICU at University of Michigan Hospital. Thank you guys again for joining me today. To start off, I just want to ask specifically you guys right here about H1N1. What exactly is it, and how is it different from other strands of flu for those at home that just don't know?
H1N1 is an influenza strain that really began in 2009, and people may remember that we had the pandemic of 2009 where there were thousands and thousands of young people that actually died of the disease. So it's a very aggressive influenza strain. And we're fortunate nowadays, it's 2014, that we do have a vaccine available to prevent the disease. It is a strain of influenza that causes a severe bilateral pneumonia, but it also causes what we call septic shock, very low blood pressure, and it also causes acute kidney injury, kidney failure, so that patients require dialysis. So today, for instance, in our ICU here at the University of Michigan, we have 13 adult patients who have severe H1N1 pneumonia, some with shock, some with kidney failure, all of them very critically ill.
Okay, and what are some symptoms that people can look for that they just to tell if they have H1N1?
Well, it usually starts with an upper respiratory infection, so you'll get a runny nose, cough, very high fever usually, sometimes some muscle aches. But in these patients, the difference is that upper respiratory infection that is mild actually translated into a severe bilateral pneumonia. And the hallmark of that is that the patients get very short of breath. They feel like they can't breathe, and their oxygen levels are very low. And then they require a breathing tube and a mechanical ventilator for breathing.
Okay, and with that, Tina, this question's for you. Did you notice that, maybe something might be a little bit more wrong than just a simple cold? Did you notice, were you like, hey, he might have the flu?
I thought he had pneumonia because he couldn't breathe, and it just got progressively worse. Like overnight, extremely bad. Like started with wheezing, panting, shortness of breath so bad he was panting, couldn't remember things, left his truck running, couldn't spell his last name, things like everyday things that he couldn't function. He couldn't function, and he couldn't breathe, and he was tired, and he couldn't make it from the chair to the couch.
Okay, and did Tony get the flu shot beforehand?
Oh, he was too busy, he thought.
Okay, and that's common, is what I've been hearing. A lot of, from what I've heard doing my research as well, H1N1 is more directed towards the young adults. Not everyone thinks, really old people get the flu or really young people get the flu, but it's mostly middle-aged, and it's almost because they think that they're invincible in a sense. What advice would you guys give someone that actually thinks that way to get their flu shot and try to prevent this from happening?
Get your flu shot.
Please.
Read up on it, really educate yourself about the H1N1. A lot of people have a misconception about flu, thinking, it's throwing up, it's diarrhea, you are sick on the couch for a few days, and then you jump right back, and this is nothing like that.
Okay, and what other myths do you guys think are about H1N1? A lot of people think, it's also called the swine flu, so you can get it if you eat a piece of meat, or they think, like you said, it's throwing up, it's not a respiratory infection. What other myths do you guys want to possibly clear up for those at home?
I think one thing people think is if you get a flu shot, you're going to get the flu. Not even close. This is not even close to what people are perceiving as having the flu. I mean, it's deadly, it's there, and you can't fight it without antibodies. So if he had it to do all over again, he'd get 3 flu shots, and he's already said that. But the minute he came aware, because he hasn't been able to communicate with us for a month and a half, he told us, I shrugged off my flu shot like a fly, And I said, yes, you did. And I think they can testify nobody in this unit that is deadly, with the deadly virus that is deathly ill, none of them have had a flu shot. So they don't, it's like your body doesn't have anything to fight with. You're down and out to start with, and you're progressively worse, and you have nothing to fight with.
Can you just go into detail about how his journey's been? Where is he at now? Where was he in the beginning?
In the beginning, we started at a hospital in Lansing, and he went from Ready Care to the hospital by ambulance. Then he came here by ambulance 4 days later. I consider brought him back from the dead. He was so bad, and there were times we didn't think he was going to make it, and they didn't think, I'm pretty sure, that we had a tough fight. It's been long, it's been hard, and it could have all been prevented with a flu shot. And I mean, we all gave up so far only a month and a half of our lives, of our routine, of the way things used to be. We're both self-employed. That's been a rough road. Fortunately, he has family down here. I have a lot of family for support. There's people here that don't have the amount of support that we've had, that don't have a place to stay. It's all stuff you don't think about until that happens to you. And it's been rough. It's been very, very rough. It's hard on all of us. So get a flu shot.
Yeah, we could say for the vast majority of our patients, they've not been vaccinated, and the average time they're spending in the ICU is about a month. And the care that they require is massive, and I think Rob could review the care day by day that they require.
And that's the difficult part for us as a healthcare facility. Caring for this huge influx of patients is they're sick, and our workforce has had to go up exponentially to care for them. And so the hours that the nurses are putting in, all the overtime shifts, it's been difficult. For us, it really started Christmas Day. Christmas Day, we had 5 calls. Day after Christmas, we had 6 calls. We had 11 calls for flu patients in the course of 48 hours. And it has slowly, in the last week or so, seems to have slowed down. But in a unit like ours, which is an ECMO unit, for 20 beds, we would usually staff with 14 or 15 nurses. During the peak of it, we're staffing with 20, 22 nurses, and trying to find that many nurses to care for these really sick patients has been a trying time. And so it's been really hard, not on the families, but on the the infrastructure of the healthcare system as well. We didn't know that this was coming this year. Like in 2009, the warnings were out. We were ready for it. We had plans in place. But those of us that were here in 2009 here now will say this has almost been as bad, if not worse, than it was in 2009.
Yeah, it's actually worse because we were not prepared. And what happened was, after the 2009 pandemic, everybody remembered that the CDC changed the recommendation for flu shots. That in 2010, the CDC recommended that anybody age 6 months or greater, so anybody older than 6 months old, needs to get a flu shot. That's very different than before, when just the young and the very old got a flu shot. Now, everybody gets a flu shot unless you're younger than 6 months of age. But what happened this year is, particularly the young group that you were talking about, the 18 to 45-year-old group,
Yes.
totally forgot about H1N1, and they didn't get vaccinated. And so that's what we're seeing, is we're seeing that age group, particularly about 18 years old to about 55, that group particularly has not gotten vaccinated, and they have a much higher rate of this very serious life-threatening disease, where sometimes, we're talking about using a ventilator, a breathing machine, to breathe for them to get their oxygen in the blood, but sometimes that doesn't work. And then they need to go on ECMO, which is extracorporeal membrane oxygenation, where we actually put very large lines in. The blood comes out of the body to a machine that puts oxygen in the blood, and then it goes back in. And again, the average time, just like the Chosiks here, you're spending in the ICU is more than a month in the intensive care unit. And then we know once they get out of the ICU, that will be many more months, 3 to 6 months, till they recover.
Okay. And for people that, get affected by H1N1, is it always this serious, or does it affect everyone that drastically, or is it just, it depends on the person?
Yeah, it's very different. So the family members here were likely exposed to the flu, and they didn't get critically ill. And why did Mr. Chosick get critically ill? We don't quite understand that. We do know that every patient responds differently to the flu.
Okay.
And so some people will get just a mild upper respiratory infection. Some people will get no symptoms. They have good immunity and they fight it. And then some people will get very, very critically ill. So it's very important to know that the host is really a factor in how severe the disease is.
Okay, and also for those that get H1N1 and then, fight through it and get healthy again, do they have more likely to get it again, or how exactly does that work? Are they?
Yeah, they are not more likely to get it again, and if we can get them through this phase of the ICU care, they do fully recover. Their lung function comes back to normal. But we do know that they still have, months and years down the line, the ravages of being in the ICU for a long time. So loss of short-term memory. Sometimes they've been in such severe shock that they lose their tips of their fingers and the tips of their toes. Sometimes they require operations because other problems have occurred. So it's a very serious disease. But if you can make it through, you can fully recover.
Okay, and I know that Tina, when we were talking earlier, said, he was very confused in the beginning. Why does that go hand in hand with H1N1 for those that don't understand?
The lack of oxygen, and it's delirium because he couldn't breathe, and he was kind of fighting it because he thinks that, he's invincible. And you just kind of fight it and you have no oxygen, and then all of a sudden your brain just kind of, he left his truck running for like 3 hours and didn't even realize it, and just stuff like that. We got to Ready Care, he couldn't fill out the paperwork because he couldn't spell his name, and it just, confusion.
Yeah, it's a common feature that we see with the H1N1 patients that they're delirious, and they require sedation so that they don't pull their lines and tubes out when they're very critically ill.
Which he did.
Yeah.
Which he did 3-4 times.
Yep. But then getting that sedation off and weaning that sedation, trying to get that sedation off, they wake up confused, and it becomes a very difficult issue.
Very. And truthfully, he's been here for 6 weeks. It'll be 7 weeks starting on Monday. And we've only had him with us for 2 days that he can, like yesterday, he asked me if he had been in a car accident. He still had no idea what had happened. So just for the past 2 days, he's been coming out of the delirium enough that he can have a full conversation with us. And even then today, there were several times that he referred to stuff that we had no idea what he's talking about. Just off the wall, and then he'd say, oh, like, where did that come from? So we're hoping we get him back totally, and they've done a great job getting us this far.
I know, it sounds like it really does. And with that, let's go switch gears and talk about prevention. Obviously, get your flu shot, get your flu shot. Every one of you keeps saying that, and that's a big thing. But what else can other people do to prevent getting the flu, getting the H1N1 specifically?
So, there's some good data on the CDC website, and one of the big things to keep in mind is this group, the 18 to 55s, this is our workforce. These are the people that are intermingling the most. So there's that whole pack herd, phenomenon where if you're sick and you're still going to work, then it's not necessarily you that having the problem, that's everybody else around you that you're spreading it to. So if you're sick, then maybe you shouldn't be going to work and spreading things.
Okay.
Yeah, if you're sick, stay home. If you're sick, stay home.
And wash your hands and cover your cough.
And then the other thing is, if you start to get an upper respiratory infection, go get tested for the flu because you may need to be treated. And we have good treatment, but the treatment needs to start early. It can't start late. If the treatment starts late, then we get to the point where, again, the disease can progress very rapidly. Within hours, you can go from being not ill to being very critically ill and having a breathing tube in.
Okay, and for the flu shot itself, when are you supposed to get that? Is it like October? Is that?
October, November.
Okay.
And it doesn't matter how early you get it, somewhere in the fall. It doesn't matter how early, because once you get it, within 2 weeks, your body should develop immunity.
Okay.
And again, every year now, it's not something that you get once every 5 years. You have to get the flu shot every year.
And we all had a flu shot, and I took care of him, and I made him soup, and I brought him drinks, and knock on wood, I've been with him every day. Yeah, you can't tell me the flu shots don't work.
So we see, one person in the family gets very critically ill, and then nobody else in the family gets sick. And sometimes the kids get sick and sometimes they don't. And again, we think it's the host, we think it's the patient and how the patient responds to
Okay.
the flu that is really the issue. Yeah.
Yeah, because I was wondering, because he let himself get so run down, like if he'd have gone, but then somebody has told me that if he'd have gone to, say, ReadyCare and they'd have given him like a Z-Pack or something, and then he would have thought he had regular respiratory
Pneumonia,
and then
regular bacterial pneumonia.
yeah, and then overnight he could have changed into H1N1 anyway, and then it would be worse because he would have thought, well, I'm on something, so I don't know.
Right, that's a common
That's
thing
the
that,
typical
yeah.
story.
Yeah.
That's
Come
what we
in,
hear all
get the
the
drugs,
time, yeah.
come home, come back in the next day, and they decompensate right in the ERs.
Right.
Most
Yes.
people,
So the docs out there don't think about flu. They have pneumonia, they think it's bacterial pneumonia. So they don't give them flu drugs, they give them antibiotics.
Yeah.
And that's a common finding that we see.
I know, I feel like they just kind of toss out those Z-Packs.
Well, and that's what I had told him. I said, well, if you're, I do think I think you need to go to, at least go to ReadyCare. No, I'm too tired. I'm too busy. I'm this or that or whatever. We had a snowstorm. He plows snow. And so I think he put it off just long enough. He was so worn down. But then in the end, it did hit him that fast. At night, he started to wheeze, and he said, oh, it's congestion in my voice box. And I said, yeah, I don't think so. So by morning, I worried about him all night laying there, but by morning, he could barely, he went down fast. Within hours. And then he was in the kitchen and he went to the couch, and that was as far as he could go. Now, had I have known he was this sick, I would have called an ambulance and,
Yeah.
But he kept insisting that, oh, I had this cold and now I've.
Yeah, it's hard because it's so. It seems like it's so close to a cold that they're just like, oh, I'm fine. I just have a cold. I'll get through it. And
Yes.
yeah.
I'd say the other thing that commonly happens is if they do go to an urgent care center, it's common that they'll do a test that's a rapid test. And that rapid test is not accurate. And so many times they'll say, well, this test is negative. You don't have the flu. But then they come here, they've got a breathing tube in, and we do what's called a PCR, a proper test, and then it's positive.
And that's exactly what happened to us. We went to ReadyCare. Although she put him right on oxygen, she recognized right away. We came in within 10 minutes. She had given him a steroid shot. She had done a chest x-ray, I believe, and she put him right on oxygen. It was that bad, and it was that fast from the time we left our house to the time we got to ReadyCare. And he could barely, like I said, I kept insisting on doing his papers, and he's like, he looked at me like, what do you, why would you? I got this. And well, in my urgency, I wanted him up at that window. I was like, no, I want you to be next in line. It was that bad. He was getting that bad. And people don't realize that. It's like, it was within hours from the time I forced him to go in, and well, by that time he had agreed with me that it was time to go in. But then by the time we had gotten to urgent care, it was all he could do to,
that's the other common piece, too.
cooperate.
It's amazing how fast you get sick and how
Yeah.
long the recovery is.
Yeah, how long did he have a cold before that?
Oh, about a week. Between Christmas and New Year's, he was kind of down. He was down a little bit. But she had a cold too, and I figured they were passing it around, and that was it, And then she got better, and she really never hit a fever, but he kept having reoccurring fevers.
Okay.
And I think at one point his temperature was like 102.9, and he was insisting I got snow to plow. So he went, and that's what happened. But so that's what we kind of thought. They were passing around a cold.
So when we have a patient like Tony that is very critically ill that comes into the intensive care unit, our first priority is to make sure that we maintain oxygen within the bloodstream, because oxygen needs to be provided to the brain. And if we don't provide oxygen to the brain will essentially die and the patient dies. And we've had a number of patients that come in very seriously ill with very low levels of oxygen, and actually their heart stops because the level of oxygen is so low. They have a cardiac arrest. Young, healthy people, because the level is so low. So in order to do that, we have a number of ways that we put oxygen into the bloodstream, and we put a breathing tube in. We let them go to sleep, so we keep them sedated in basically a drug-induced coma. We do a number of maneuvers to try to get the lung to actually exchange oxygen. And that means sometimes putting them on their belly. That means getting the fluid out of the lungs. So we put them on what we call diuretics, medicines to actually get fluid out of the lungs. We sometimes use high pressures within the lungs to open up the little sacs, what we call the alveoli. And as we said, we have a number of other strategies, other drugs. We have a drug that's called inhaled nitric oxide that helps again to get oxygen into the bloodstream. And then the very last measure that is a very useful measure when none of our other strategies work is to put them on ECMO that we spoke about, where we don't use the lungs anymore. We actually just pull the blood outside of the body, put oxygen into the blood outside the body with basically a bypass machine, as if you were having heart surgery, and then put the oxygenated blood back in. That process takes, on average, 3 to 4 weeks to get the patient's lungs to actually begin to improve. And then once the lungs begin to improve, we have to get the patient to start breathing on their own. And at that point, we have to wake them up. And that's the challenging part. Now, waking them up, they've basically been asleep for weeks. Now we're waking them up and trying to keep them awake and let them breathe again. And that is very challenging. But during this whole period of time, many other complications can occur. So heart abnormal rhythms, kidney failure, liver failure, the delirium that we spoke about, that they try to pull things out.
Blood pressure up and down,
Up and down, shock, requiring medicines to keep the blood pressure up. So it's a very challenging course in the ICU, which is why it takes so long. And on average, again, it takes about a month to see a turnaround when patients get this critically ill. And many times, as you mentioned, many times, sometime during the day or sometime during the night, we're right on the brink of death, that we can't get enough oxygen in, or the blood pressure is very low, and we're right on the brink of the patient dying. And then we finally make a little bit of progress. It's very, very challenging.
It's constant. It's not, they don't tuck patients in bed here at night and come and check on them in the morning. It is constant. It is every 10, 15 minutes. When he was at his worst, it was constant. It was always somebody, they had to be right there. It's just like Rob said, it's all the time. It's not something that you go on break and you come back and your patient's still fine. It's somebody there all the time.
And we can say, and Rob, you should talk about this, that when a patient comes in, Mr. Tosa came in very, very critically ill, there are sometimes 2, 3, and 4 nurses, along with 2, 3, and 4 doctors, taking care of one patient that is just, again, on the brink of death.
Right. And that's the hard part that we've had is, in a perfect world, of course, you're always going to have some sick patients. But typically you would have, a handful of sick patients and then what you consider a normal unit. But then when you change the makeup to where you have 13, really sick patients requiring that level of care, it is exceedingly challenging to keep up with them. And when they first arrive, transport is a very hard piece of the disease process for the patients. Transport, a lot of times they don't do great on transport, and so we play a lot of catch up. And so it's very hard. There's always getting them admitted, getting all of our new processes started requires a lot of teamwork. So it's busy.
And then I think she mentioned earlier when I was talking to her before the actual interview itself, that they can give plasma to the patients in order to help them make antibodies so they don't have to make them themselves. Is that correct? Can you explain that a little bit?
Actually, that was kind of a study that a different doctor was working on, and I kind of chose Tony to be a part of that because we had plateaued for so long. We were at a point where it was doing no harm to try something new because we hadn't made any progress, and I just felt like the sacrifice was greater than. It's a harmless. It's not like it wasn't like a trial drug or anything. It's something that happens all the time. It was more of a routine thing, so.
Yeah, it basically is a study that is by the National Institutes of Health, where they use convalescent plasma. So basically, someone had H1N1, they now donate their plasma, and their plasma actually has antibodies to actually fight the virus. And so because he had plateaued, he wasn't really making any additional progress, there would be potential benefit to
Yes.
giving it to him so that he could better fight the viral infection.
Okay. And have they seen an improvement because of that yet, or is it too early to tell?
Well, they have seen some improvement in some patients, but the study is not yet done. So we won't know for sure until the study's done.
Yeah.
Okay.
Another member of the family.
This is Gizmo. He actually, I think a lot of things too, people don't realize how much your life changes on the outside of the hospital. He was originally my dog. I went to college, and he kind of is my dad's buddy. And so I think it's been really hard on him to not have my dad around all the time, and every time he hears a car in the driveway, he peeks out the window just waiting for him to come home. And I think even seeing him in the state that my dad's in now, I think it's hard on him. He kind of doesn't really understand. The first time we came to visit, my dad couldn't speak because he had a trach, and he couldn't really talk to him like he does. And I think he was kind of confused, like, what the heck is going on? This man usually picks me up and talks to me and says I'm cute all the time, and it was really hard on him too. You know, people don't think about that, but
Pet therapy.
But this is a really important feature of our ICU. You know, we're a patient and family-centered ICU, and we feel it's very important for patients to recover to have their pets close by. So we do allow pets to come into the intensive care unit as patients are recovering. It motivates them to get better.
Yeah.
That's awesome.
And it did help today, I think.
So can you please go into detail about the dangers of H1N1?
So influenza is of various types. There's influenza A, influenza B, and this is an influenza A type. It's a subtype of influenza A, but this is a much more deadly disease. Every year that we've seen patients with H1N1, when they get this critically ill that they need to be in the intensive care unit, we know that the overall death rate is approximately 30%. That means out of every 10 people that come into the ICU critically ill with H1N1 pneumonia, 3 out of those 10 will die. They will not make it. And again, this is in an age range when normally for other diseases we can save those patients. So it is a very life-threatening disease.
Is there anything else that you guys want to add on this?
It takes a day at a time, an hour at a time when patients are
Absolutely.
this critically ill, because we see that they can get a little better and they can get a little worse. And it can be very frustrating, but I think you said the right thing. Don't give up hope. Because if we do our job right, we can get them through.
There were times when I would update my Facebook status and come back 20 minutes later to his room and things had changed and he was worse, or he was better, or something had drastically changed that we hadn't counted on. But we've actually been able to avoid a lot of complications. We've been lucky.
Well, you guys have been very strong through all of this, and you guys sounds like are doing a great job here at U of M. That's all the time we have for this edition of InnerView. Remember, you can like us on Facebook, follow us on Twitter at Home TV, and you can also use the hashtag InnerView. I'm Amanda Chudnicki, and thank you for joining us.